everyone, I hope you can hear me. Today we're going to be talking about biologic response modifiers. Not a lot of content in this module, so yay for us, right? Okay, so let's start with this. So what are interferons? That's really what we're dealing with. So they regulate the immune system and help to improve resistance to invading microorganisms. And they help reduce cell proliferation. So we have a cell that has been attacked by a bacteria or a viron. And what does the cell do? Well, it knows it's going to die, but what it does is it sends out a chemical messenger so that the other cells around it may survive the virus, right? So it's chemical signals. Those are what our interferons are, and they're sent to the other cells. This is high tech. Like, they didn't have this kind of stuff when I went to school. Well, they kind of thought they knew about it. Now they're engineering medications and cancer therapies and lots of things based on this. So stay tuned. In the future, we may have more and more medications and therapies and biologic therapies to treat things such as cancer or multiple sclerosis or any of the autoimmune diseases. So stay tuned. Okay, or even an answer to the big worry we all have about antibiotic resistance. This may be the future of that. Okay, so stay tuned. Okay, again, so what an interferon is, really, I'm not really testing you on this, but I wanted you to understand why would we bother to give a patient an interferon. So the host cell is infected by a virus. It makes an interferon, and then unfortunately that cell dies. What it does is it sends the interferon to the other cell, and then that cell may have some protection against the invaders. So it's a wonderful technology. Well, we didn't come up with it, but it's a wonderful thing in our body, and hopefully we'll be able to maximize that for future generations of medications. In the meantime, we do have interferons that we get from people, and so the alpha. So that's produced by the beta cells, T cells, macrophages in response to a virus or a tumor. Remember, our body constantly patrols itself for cancer, which is why a young intact immune system is less likely to succumb to certain cancers. And as people get older and their immune system becomes less efficient, there are certain cancers that pop up more frequently. Okay? So this is immunomodulatory, meaning it limits the ability of viruses and cancer cells to replicate, right? It enhances natural killer cell activity, awesome for cancer, and it's used to treat some cancers like leukemia and also some chronic viral infections. More and more chronic viral infections like hepatitis and HIV are being treated with interferons. Okay, now for alpha, common side effects include flu-like symptoms, right? The flu, you feel yucky because we've activated your immune system. All right, fatigue, irritation at the injection site, meaning we activated your immune system, and your immune system's like, huh, what's going on? And you're going to see an immune response. Maculopapular rashes, so like a Hy-Vee rash on the trunk and extremities, and alopecia. So this can happen. Unfortunately, hair loss can happen after 4 months of therapy. All right. Beta is used to treat multiple sclerosis, right? It enhances suppressor T cells, and these are the ones that tell the immune system to turn off. Remember, an autoimmune disease is when our body is attacking something it shouldn't be attacking, part of the self. So what we're going to do is activate T cells, the turn-offer, I don't know how to say that right, the T cells that tell our immune system to shut down. That's what this will activate. All right, it reduces cytokines, which limits inflammation, and it limits the immune response, right? Okay. It also limits the ability of lymphocytes to move in and out of the central nervous system. Why do we care about that for multiple sclerosis? Well, MS is our body attacking our nervous system, so that's why it's so horrible and pervasive. So the fact that we can limit lymphocytes into the central nervous system is a plus for this disease. Okay. Gamma activates natural killer cells, right? And that's used to delay the progression in patients with chronic cancers, okay? Some of the blood dyscrasias especially, all right? Remember, biologic response. We're trying to mimic or help our body's own ability to fight these things off. That's what we're doing here. We're not directly killing anything, but we're activating our own immune system or turning it off in the case of multiple sclerosis so that we can make these people better. All right. So what's a colony stimulating factor? First thing you have to remember is way back when we talked about how our blood cells are made, we have to remember that an action of the hematopoietic colony stimulating factors is in our bone marrow. All those little, little itty bitty baby cells are waiting to be activated and told what to become, right? So they're either going to become a red blood cell or the stem cells, or they're going to become a lymphocyte or a platelet, all of that. And they just need the right colony stimulating factor to come in and say to the bone marrow, which is basically a blood cell factory, what do you need to make today? Okay. So it regulates the growth, maturation, and differentiation of bone marrow stem cells. Remember, the stem cells are not differentiated, meaning they're going to become some kind of blood cell, but we don't know which kind. It needs the right chemical key to decide that, all right? So why do we give it? Well, it decreases the length of post-treatment neutropenia. We have, I work on an oncology floor, and one thing when we talk about cancer especially is a lot of these therapies will limit the immune response. So we're killing off white blood cells, not always ideal. In some, though, blood dyscrasias like leukemia, that's the goal of therapy, right, is to kill those things off. But we're not talking about those patients. We're going to talk about someone, let's say with breast cancer, who comes in and needs to have a mastectomy and then chemotherapy. Well, part of chemotherapy is it kills off most of our immune response. So we may need to have a patient on a colony stimulating factor to boost that with the, we're going to kind of augment and say to the body, you need to make a lot more white blood cells, all right? Permit the delivery of higher doses of drugs. Like I said, sometimes we may need a high dose of a chemotherapy in order to treat a certain cancer. And if we did that normally without a colony stimulating factor, that patient would be open to any kind of infection, also anemia. Okay, so not only does the bone marrow make white blood cells, but it also makes red. So we could have a patient that would die from the therapy we're trying to deliver if we didn't have these colony stimulating factors. Okay, we want to enhance macrophage or granulocyte tumor, virus, and fungus destroying ability. So we want to activate the immune system. We want more white blood cells. We will give a certain colony stimulating factor. And to prevent severe thrombocytopenia, which is the lack of platelets after myelosuppressive therapy. So all of our blood cells are made in the bone marrow, right? And we have different things that we can give to stimulate that factory to produce whatever kind of cell we want, all right? And that's what a colony stimulating factor is. All right, so erythropoietin stimulating agents. So that's red blood cells. So if we have a patient who is really, really anemic, or we have someone on chemotherapy, which becomes pancytopenic, meaning all of their blood cells are in low supply. Someone on chemo or some of the HIV drugs can become anemic and neutropenic, meaning they don't have enough red blood cells, anemic, or not enough white blood cells, neutropenic. All right. So we have a patient that is probably anemic or, having chemotherapy, or is a dialysis patient, you name it. And we would give them epoetin alpha, or the brand names are Procrit and Epigen, right? And this stimulates the production of red blood cells, right? And we use it for patients in renal failure. So remember, in normal physiology, our kidneys are sort of the regulators of that, and they kind of, because the kidneys filter all the blood as it goes through multiple times a minute, they notice if red blood cell count is low. So what do? The kidneys kick out some erythropoietin. That messenger goes to the bone marrow where our blood cells are made, and it says, hey guys, we need to up our production of red blood cells. And that's how that works. So if you have a patient whose kidneys aren't working, we lose that regulatory response. So we're not going to have erythropoietin just going out like it normally would. So dialysis patients will often get a dose of epoetin alpha or Procrit at their dialysis appointments on a set schedule. All right, and that totally makes sense. So always remember that the kidneys are responsible for that response. So if you have a dialysis patient or someone maybe without kidneys, if they've had kidney cancer, they're not going to have this. They're going to need this augmented by this medication. And this is given IV or sub-Q. So this isn't a pill we can give them. It's done by either intravenous or subcutaneous, okay? And most often it's given subcutaneously. All right, or the chemo-induced anemias, just like I said. If we're giving chemotherapy, which is basically a poison, and we give that to patients to kill off a certain cancer, well, we're also killing their ability, in many cases, to make red blood cells. So we're going to give them epoetin alpha. All right, what are some contraindications to this? Well, we're giving this to someone who's supposed to be anemic. That's the only time we give it to them. So if their lab values indicate they're not anemic or they're almost not anemic, so let's say a hemoglobin of like 10, 11, or 12, then they don't need this. We could end up actually with the opposite issue in too many red blood cells. So what we do is we would monitor lab values, and if their hemoglobin and hematocrit are normal, then they don't need this. Obviously, right? So this is only for people who don't have enough red blood cells. So if they have enough, we're not going to give it. Okay, so this is just one of those, I love the memory notebook of nursing. Every time I have a slide that applies, I make sure that I put it on, right? So this just talks about it. And it shows you the kidneys sitting there, and that we need the kidneys for this to happen. It talks about the doses, right? And that we only give it sub-Q or IV, right? Okay. So down here, the little dog with the lady on the picture, it says monitor the CBC with differential. And the other thing is, and this is a great point, I love that I put this slide in here, is whenever you need to make something, so we know that the stem cells for all these blood cells are in our bone marrow, and we're going to need epoetin alpha to tell the factory that it needs to make more red blood cells. Wonderful. We also need to make sure the factory, our bone marrow, or our body, has all of the ingredients to make said blood cells. So what do you need to make a red blood cell? Well, we need epoetin alpha to tell the factory to turn on in the first place, one. We also need iron. Remember, hemoglobin is made with iron. So if your patient is iron deficient, you are not going, no matter how much epoetin alpha you give them, you're not going to make good red blood cells or enough. So make sure their iron levels are normal. You need other things like folic acid and vitamin B12. Remember, there's a couple of different types of anemia. One of them is the iron deficiency, one is the B12 deficiency or pernicious, and the other is a folic acid, right? So make sure that you're monitoring all of those healthy nutritional things. And if patients are taking iron supplementation by mouth to help this work, you cannot absorb iron into your body without vitamin C taken at the same time. If you go to CVS or Rite Aid or Walgreens this summer, walk around the aisles and look, and you'll see that the newer combo products for people who are taking iron come with B12, folic acid, and vitamin C. And the reason is for that iron absorption, okay? So the whole point of epoetin alpha is to increase hematocrit and hemoglobin, right? So if those levels are already normal or they're almost normal, we would consider not giving this. This is given for profound anemia, all right? Low hemoglobins, like 8 or below, all right? So keep that in mind. Okay, so now we're going to talk about a granulocyte colony stimulating factor, right? So those are our white blood cells, right? So we have filgrastim, Neupogen, right, which is given IV or subcutaneous, or pegfilgrastim or Neulasta, all right, and that's also given subcutaneously. So we're augmenting an additional our body to make additional white blood cells. So a lot of times people will feel kind of fevery, nausea, vomiting, like fluish. Does that make sense? I think we're telling your body to make more white blood cells. They're not going to feel very well. Okay. So sore throat, diarrhea, fatigue, headache, cough. They're going to feel like they have the flu. All right. Considerations. So we want to avoid within 24 hours of receiving chemo, because we've delivered a poison to their body to kill their cancer. Well, if we give this agent too close to chemo, then any cells that come out of the gate are going to get killed too. So we usually wait 24 hours until that chemotherapeutic agent is out of the body before we stimulate. There's this really cool commercial. There's new products now, and I forget which medication it is. So what would happen is the patient would go in for chemo one day, and then within a day or two, they go back to the office and they get an injection of Neupogen or Neulasta. Well, within that first few days of chemo, those patients feel like death. And trying to limit them having to leave their house, especially when they're immunosuppressant, is they have these new products where they're like a strap-on device that goes onto the back of the arm, and it's set on a timer, and when the dose is due, an automatic subcutaneous injection is delivered to the patient while they wear the product, which I think is actually really cool. So they don't have to come back in, and a visiting nurse doesn't have to come out and see the patient, and they're getting their granulocyte colony stimulating factor at the right time. So new and more improved. Pretty soon people are going to have little pouches on that they wear instead of having to come in for their injections. It's very exciting. Okay. So the next part of this is drug use by health professionals. And I really wish we didn't even have to talk about this. This is a pervasive, we have an opiate crisis in the United States. I know you've all heard this in mental health. And unfortunately, nurses as a profession, we are surrounded by opiates. If you work in a hospital, I can't even think, I worked the other day, how many opiates I gave in one shift. And I work on an oncology floor, so I do understand that I give more than maybe, some other places, but an orthopedic floor and an oncology floor and a surgical floor, we give lots of opiates because that's what you need for acute severe pain. Unfortunately, what can happen is those enticements are available, and people do things that they probably shouldn't when they become addicted. It is, a disorder, and unfortunately, nurses are not immune to that. All right, so it is a serious concern. We have a huge issue with this in the nursing population. So about 10 to 20% of nurses have a substance use issue. And then 3 to 6% demonstrate impaired practice because of drugs. I have been involved in situations where I've been working with a suspected impaired nurse. And first things first, nurses like to protect their own. I would never want to jeopardize the career or the license of a fellow nurse. But with that said, if you suspect that you have a coworker that is abusing substances while working with patients, you have a responsibility to report that. Now, you can do, many places have anonymous reporting. You can also report directly to the state if you feel more comfortable doing that, okay? Why does this happen? One, chronic fatigue and burnout. We don't work in the happy, fun, sunshine company. We're nurses, and we're surrounded by sick people and dying people and chronically ill people, and the workload's heavy. A lot of places cut staffing to save money, and that makes our job even harder. And then there's more and more and more regulations, right? So chronic fatigue and burnout. Job dissatisfaction. You work every shift short-handed, running around, not taking a break. Guess what? You're not going to like your job very much. Also, the false belief that if you know about these drugs and you understand how they work, that somehow that makes you immune to a drug problem. It absolutely does not, okay? And the last is access to drugs. We have access to all of these medications. So we have more access than the general public. We can get things, the pure version of these pretty easily if we're sneaky enough. All right, so characteristics of an impaired nurse. Changes in personality or behavior. Now, not everybody who comes in nasty has an abuse problem or a substance use problem. But if you notice someone that has normally been, prompt and on time and easy to work with, and now they're irritable, they're coming in late, things like that. Poor judgment, making a bad decision about a patient. Errors, med errors, charting in the wrong chart, trying to give a med to the wrong patient. Inappropriate behavior, illogical documentation. This was something that led to the coworker I was talking about, is you try to read a note and it made no sense. There was everyone makes grammatical errors and mistakes, and this was incomprehensible. No one could figure out what they were trying to say. Inappropriate drug wasting or other signs of drug diversion. We're going to talk about that a little more. But from your limited clinical time that when you give an opiate, if you're not giving the entire dose delivered by the medication management system or the Pyxis or the whatever the automated machine is. So let's say we're drawing a vial of 2 milligrams of morphine, and the dose that we're going to deliver to the patient is 1 milligram of morphine. Well, we know that remaining 1 milligram needs to be accounted for. In the older days, you just throw it out. Now we need to account for it. So two nurses usually have to sign off that this medication was wasted, or the remaining dose is actually sent back to the pharmacy for verification. It does depend on where you work, but there's something called a witness. You're not the only license that's going to sign this off. Now, what can that, if you have two impaired nurses working together and they're always wasting together and then they're sharing the proceeds, you can see how easily you can get around this type of process, right? So, or a lost dose. So a nurse that's constantly saying, I dropped the pill into the sink. That happens 3 times a week. We're going to be like, okay, don't stand near the sink when you open up your morphine pills. All right, so just bear in mind that that's another sign that they're going to be watching to see if there's any inappropriate drug wasting. So here's drug diversion. Okay, so there was a case not too long ago where a nurse anesthetist, or it was an anesthesiologist, okay, regardless, was in a situation where they were drawing up multiple doses of opiates and other controlled substances. And what happened was the person was injecting themselves and then using the same needle. So this can lead to the use of contaminated needles, right? And the spread of bloodborne pathogens. So this, I think this person, it was Hep C, I want to say, but there are multiple stories in nursing literature where you find that there's been spread of HIV and hepatitis by the use of contaminated needles by impaired people. Drug diversion, by the way, is a crime. So if you're stealing, that's what you're doing. You're stealing drugs. You're stealing a medication that you legally said you gave to someone, and you're using it on yourself, and it is a criminal offense. So if you're caught, you can be prosecuted and jailed. All right. Okay. So management, how do we fix this? That would be the $1 million question, right? So management depends on the state the nurse is practicing in. One of our great things about America is every state kind of does things on its own. So in some states, nurses are just fired. So they catch you at Rhode Island Hospital and they you diverted, and they just fire you. And they don't get reported, and that leaves them free to go work at another facility, all right? Co-workers definitely should report their suspicions to their manager or nursing supervisor. I know. I would hate to rat out somebody and then find out that it was nothing. But wouldn't you rather err on the side of caution instead of having an impaired nurse take care of one of your loved ones, okay? Don't cover up for the impaired nurse, okay? They're caring for patients while under the influence, and that's just not forgivable, okay? And now, a lot of states offer something called a non-disciplinary option for nurses to enter rehab or a similar program. So reporting and statewide knowledge of what's going on with the nurse is the most ideal, okay? So what's the Rhode Island Nurse Practice Act? Okay, here's an excerpt. Pursuant to the statutory provisions of blah, 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 blah. The board saying that they have the right to deny, revoke, or suspend any license or otherwise to discipline any person licensed upon proof that they are unfit, right, because of negligence or habit. So like if you have a drug problem, they have the right to deny or suspend your license, or habitually intemperate or is addicted to the use of habit-forming drugs. So alcohol, opiates. So if you're, what does that first one mean? Well, if you're coming in really hungover every morning and it's impairing your job, they can do that too. Okay. All right. So we have in Rhode Island a voluntary, non-disciplinary program. Okay. So it has to be approved by the Board of Nursing. Employers are made aware because they have to watch out for the person too. We're trying to help someone get better. So they're made aware the nurse is participating in a program so they can keep an eye on their employee. Nurses have to agree to random drug testing, okay? Disqualification occurs if you leave the program or you have a history of noncompliance. This is your 5th time in the program and you can't do it, or if you get convicted of a crime. So you get caught diverting or selling or anything related to the substance use. They can be, or if you have a DUI or things like that, you can be brought up in formal disciplinary action and disqualified from the non-disciplinary program.